All right, let's talk about the neurology, and first topic is the neural development. So in the neural development, first of all we have the notochord. The notochord is actually arising from the mesoderm, okay, and the notochord then become the neuroectoderm. So actually the notochord is telling the ectoderm to become a neuroectoderm, okay, and form a neural plate. So first thing is the notochord. The notochord will differentiate the ectoderm into the neuroectoderm, okay, and form the neural plate. So this is the notochord, and it is forming this neural plate, and the neural plate becomes the neural fold, okay. These are the sequence of events. So the neural folds then it will form the brain and spinal cord, and also it will form this neural crest cells, which becomes the autonomic nervous system. So in order to make it easy, just remember the sequence, okay. The first step is that we differentiate the ectoderm into neuroectoderm and neural plate. How? It is because of the notochord. So basically the notochord is telling the ectoderm that please differentiate into the neural tissue, okay, form a neuroectoderm, form a neural plate. So once it's just follow this diagram from above and below. The neural plate becomes the neural fold, and the neural fold will further goes and form this neural tube, and the neural tube, then the periphery will regress and form the neural crest cells. So regarding the exam point of view, this is important that the neural tube is forming what? It's forming the brain and spinal cord, and this neural crest cells, this is forming the peripheral nervous system. Now let's read this. The notochord induces overlying ectoderm to differentiate into the neuroectoderm and form a neural plate. Notochord becomes nucleus pulposus of the intervertebral disc in adult. So it's actually doing nothing except it's just talking to the ectoderm to become neuroectoderm and neural plate. And by itself, the notochord is doing what? It will form later on in adult life. The notochord becomes the nucleus pulposus, which is the central part of the disc. So the central part is nucleus pulposus, the peripheral part is the annulus fibrosus. I am talking about the disc between the vertebrae. So the neural plate gives rise to a neural tube and neural crest cell. This is the same thing. This is a neural fold, it becomes a neural tube. The neural tube will regress, the periphery become neural crest cells. So actually the important thing is that the neural tube will give rise to the central nervous system and the spinal cord, and the neural crest cells becomes the autonomic nervous system. So what they are basically, a lateral wall of the neural tube are divided into the alar and the basal plate. So now when you the neural tube, when it regress the peripheral, like the neural crest cells, it will form the spinal, it will form the autonomic nervous system. So now here they are saying that the lateral wall of the neural tube are divided into the alar and basal plate. So look at this structure. This is basically the lateral wall of this neural tube, okay. This is the neural tube. So the lateral wall, its lateral area becomes like this. It will form this anterior and posterior area. So the we have this motor and sensory spinal cord. So the dorsal spinal cord is basically for proprioception, vibration. So it's purely a sensory in nature. So dorsal sensory on this one and this one. So this is the alar plate, and the ventral on is the basal plate, okay. So dorsal and ventral, alar and basal plate. If you look at this structure, this is the regionalization of the neural tube. Here I would like to add something important, is that there are certain points here that the neural crest defect. The neural crest defect is basically the ostium secundum, the VHD. These are the neural crest defect. The adrenal medulla, the neuroblastoma, it's also a neural crest cell defect. The melanocytes plus the germ cells, these are also neural crest in origin. So along with that, if you have the sonic hedgehog protein, the holoprosencephaly. So those are basically the holoprosencephaly. Which gene is involved? You will be saying like it's the sonic hedgehog protein. So here one thing more. If you look at here, the alar plate, the dorsal one, which is the sensory, induced by the bone morphogenic proteins, BMPs, while the basal plate, the ventral motor, induced by the sonic hedgehog protein. All right. So these are the some of the embryological structures that we must know. And alar is basically, you can remember it like alar is for afferent, and the B is basal is for bafferent or motor. Okay, just remember it, afferent and bafferent. Afferent is going towards sensory, bafferent is coming and motor. Now let's talk about this other structures. Okay, now we have this three primary vesicles: the forebrain prosencephalon, midbrain meson, and hindbrain rhombin. Just remember it, prosen, meson, and rhombin. The sequence is like this. So the prosencephalon becomes the teleon and the diencephalon. Now the telencephaline will form a cerebral hemisphere and the lateral ventricles, while the diencephalon will form the thalamus, hypothalamus, and retina, and the third ventricle. Midbrain, which is the meson, it will form the mesencephalon, and the mesencephalon becomes the midbrain, and beside the midbrain, cerebral aqueduct. The fourth ventricle, first we have the lateral ventricle, the CSF flow. If you remember, the lateral ventricle, from the lateral ventricle, the CSF will go into the third ventricle through the foramen of Monro, and from the fourth ventricle into the all right. So I think it's the lateral ventricle. From the lateral ventricle, the fluid will go into the third ventricle through the foramen of Monro. From the third into the fourth through the cerebral aqueduct. Here the cerebral aqueduct. That's why I'm telling you this. From the lateral to the third ventricle through the foramen of Monro. From the third to the fourth ventricle through the cerebral aqueduct. From the cerebral, from the fourth ventricle into the subarachnoid space, is through the foramen of Luschka and Vigendi. Luschka is laterally, Vigendi is medially. So that's how the CSF flow is going from the like in this way. It will be coming downward, and finally it will reabsorb through the through the subarachnoid space. It will go into the there are small openings through which the fluid is reabsorbed, and finally. So from the hindbrain, the rhombencephalon, we have the metencephalon, myelencephalon. Metencephalon becomes pons, cerebellum, and upper part of the foreventricle. Myelencephalon, medulla, and lower part of the foreventricle. The brain stem contains the midbrain, pons, and medulla. Just remember this as well. Now let's go to the next central and peripheral nervous system. So the neuroepithelial, basically the neuroepithelia in the neural tube, and the central nervous system: neuron, CNS glial cells, astrocytes, oligodendrocytes, ependymal cells. So we have the neuroepithelia in the neural tube. So we said that the neural tube becomes the central nervous system, which contains the brain and spinal cord. So within this neural tube there is neuroepithelia that is forming the CNS neuron, the glial cells, okay, and which contain the astrocytes and oligodendrocytes and the ependymal cells. So we'll be reading each and every one in the upcoming session. Just remember that these are the CNS glial cells: astro, oligo, ependymal cell. This ependymal cell is basically in these famous for the CSF formation within the ventricle. And then we have this neural crest cells, which will form the peripheral nervous system, contain the dorsal root ganglion, autonomic ganglion that contain the sympathetic, parasympathetic, and the enteric, and the peripheral nervous system glial cells like the Schwann cells, satellite cells, adrenal medulla. So the myelination in the peripheral nervous system is done by the Schwann cells, while in the central nervous system the myelination is done by the oligodendrocytes. Okay, and then we have the adrenal medulla as well. So all these structures arise from this neural crest cells, and if there is any problem with this neural crest cell, then that will lead to the abnormalities of these structures. We have this mesoderm, and the mesoderm is like the microglial cells. Okay, the microglial cells from the mesoderm, and these are basically the macrophages within the CNS. So these were about this central and peripheral nervous system. Remember, then let's move to the neural tube, and within this neural tube we have this neuropores fail to fuse by 4th week of development, and persistent connection between the amniotic cavity and the spinal canal. So it is associated with diabetes, folate deficiency during pregnancy, increased alpha fetoprotein, and in the amniotic fluid and the serum, except spina bifida occulta, normal alpha fetoprotein. Increased acetylcholinesterase in amniotic fluid is a helpful confirmatory test. So basically the connection between the amniotic cavity and spinal canal will remain there. Normally it should close by 4th week of development. So if the connection is remain there, then it will lead to the neural tube defects. So I will give you the concept that how this alpha fetoprotein is increased. Basically, alpha fetal protein is the fetal specific globulin, and it's made by the fetal yolk sac and the fetal organ. So its function is unknown, although it is excreted by the fetal kidneys, and by the 16 to 18 weeks we measure the maternal serum level. If it's high, it may indicate the neural tube defect. Okay, and the interpretation is basically complex. So we just follow up the tests. Amniotic fluid, alpha fetoprotein, it's required, which require like the amniocentesis, and the amniotic fluid acetylcholinesterase level, we also check that, and if both is elevated, then we said that strongly suggests the neural tube defect. So we check the neural tube defect, screening with ultrasound and maternal blood level of the alpha fetoprotein, and screening is also done for Down syndrome. I'm just giving you the broad, the importance of this whole alpha fetoprotein and this ultrasound finding. So if there is increased nuclear translucency by ultrasound, and if the serum marker is like if there is any increased elevated level of this alpha fetoprotein, then it may give you the clue regarding the Down syndrome. So we do this triple screening, like the alpha fetoprotein level, estradiol level, and HCG level. These all three are important for the Down syndrome. These are the prenatal screening basically. So let's come back here. It's simply the in the spina bifida occulta. Remember, first let's discuss this. We said that the increase type 1 diabetes, obesity, remember, valproic acid and carbamazepine, all this can lead to this problem. Okay, there's not only the folate deficiency. So it can be type 1 diabetes, it can be obesity, it can be valproic acid or carbamazepine. All these can lead to this. So basically the problem is that why this happened. It's because of the the folate is required for DNA synthesis, and it helps in the rapid cell division. So for the rapid cell division we need the folate. If the folate is deficient, that will lead to defective neural folding, and if there is defective neural folding, it will lead to the neural tube defect. So then we have this, like if you look at this, there are different types of this neural tube defect, and one of the type, we have this the whole neural tube is intact, this normally, and the vertebrae are formed. So in the spina bifida occulta, there is the spina bifida. So the spina bifida is basically the bifid spine. The spine is basically split. That's why this is the spina bifida occulta. And you have the completely normal, it's completely the meninges and everything is intact here. Only the vertebra is split. So here you will be having the the failure of the caudal neuroport to close, but there will be no herniation. So there will be a tuft of hairs here, as you can see, and so the neural tissue is actually normal. Only there is a vertebral defect. There will be no neural tissue problem, and the defect is usually mild defect. Then we have this what we call this meningocoele, in which the meninges is herniating is through this spinal defect, and this is the only the meninges herniate through the bony defect. In the myelomeningocoele, as you can see, there is meninges, the neural crest, and the it's all herniated through the bony defect, and you can see the skin or thin skin may be thin or may be absent, and this one is dangerous, myelomeningocoele. Here still the skin is intact. If you look at this, let's read this what actually this means. Spina bifida occulta, failure of the caudal neuroport to close but no herniation, usually seen at the lower vertebral level. Dura is intact, associated with the tuft of hair skin dimple at level of bony defect. Meningocoele is basically the meninges herniate through the bony defect. Okay, only the meninges are herniating through the defect, as you can see here the meninges. Myelomeningocoele, as the name indicates, meninges and both the myelomeningocoele, myelon, both the neural tissue plus the meninges, both are herniating through the defect. Myeloschisis is it's also called the racheschisis, and it is usually the tissue is exposed, unfused neural tissue without skin on meningeal covering. It's the dangerous one, and it's failed to close at all. So basically the neural tissue is exposed. If you remove the skin, if you remove the meninges and only neural tissue is visible, that's myeloschisis. Anencephaly is basically the failure of the rostral neural port to close, and there will be no forebrain. There will be open calvarium, and clinical findings including the polyhydramnios, no swallowing center in the brain. So basically, the concept of polyhydramnios is that the kidney is forming the urine. The urine is going to the in vitro life. When the in vitro life the urine is formed, the urine goes into the mouth, and then the fetus swallow the urine, and the urine may goes into the the chest as well, the respiratory system. So by this way, this is basically the you can say the amniotic the fluid or the urine of the kid, that is baby, that is forming, going into the mouth, going into the GIT, going into the respiratory system, and by this way this whole system is going on. But if there is anencephaly, then there will be a no swallowing reflex, there will be a no swallowing, so the patient will not be able to swallow the fluid, okay, or the amniotic fluid. So that will lead to this condition will be incompatible with life. There will be a respiratory failure, there will be abnormalities of within the GIT. So all these problems will be there. In order to have develop respiratory system GIT, we need this pathway, that the amniotic fluid or the the urine that is going into the kid mouth must be swallowed, must go into the respiratory system. So this is important for the development of these organs. Now let's go to this brain malformation. Okay, so in the brain malformation, I'm not describing these images. These images describe itself. Okay, you just look at this, read it, and move ahead. A brain malformation. So in the brain malformation, we have this holoprosencephaly. It's often incompatible with postnatal life. Survival may be profoundly disabled. First, holoprosencephaly is basically the failure of the forebrain or the prosencephalon to divide into the two vertebral cerebral hemisphere, and the developmental field defect usually occurring at weeks 3 to 4 of the development. It's associated with the sonic Hedgehog mutation. May be seen in Patau syndrome 13 trisomy, fetal alcohol syndrome, and it presents with the midline defect, monoventricle, fused basal ganglion, star in a. You can see here the basal ganglion here is like it's completely fused, it's one, and the fused basal ganglion, cleft lip, cleft palate, hypotelorism, cyclopia, proboscis, increased risk for pituitary dysfunction, diabetes insipidus. So basically, if you look at this holoprosencephaly, you can just remember it like this, that there will be a single cerebral hemisphere. It will not be divided. Okay, so holoprosencephaly, single cerebral hemisphere, it will not be divided. So there will be a midline defects, the cleft lip, cleft palate, the hypotelorism. Okay, you can see here, this is the hypotelorism, the proboscis, non-functioning nasal structures. Okay, no nasal cavity is there, no nasal structure over there. Then we have the single central orbital fossa. You can see single central orbital fossa. Okay, proboscis, and the single nostril nose, hypotelorism, close set eyes. You can see the set closed eyes are near to each other. This is the closed set eyes, and you can see here the single nostril. The nostril, there is no in between septum within this nostrils. Normally we have septum, but there will be no septum in here. So like this can be presented with different pictures. You can see holoprosencephaly spectrum. Okay, can be cleft lip, cleft palate, can be single nostril. Okay, closed eyes, the hypotelorism, proboscis, non-functioning nasal structure. It can be central orbital fossa. Okay, so all of these are remember basically the proboscis mean non-functioning nasal structure. Okay, now why this happened is because of the forebrain. The forebrain is basically it normally divided into two cerebral hemisphere. So there will be all these problems, developmental field defect, and 3 to 4 years of the development. Why this happens? Sonic Hedgehog mutation, right? So these are about the structures, and let's move to the one more thing, like why sonic Hedgehog mutation is causing this is because of the loss of midline signaling. Okay, the midline structures cannot separate. If there is SHH mutation, there will be no midline signaling. There will be no the midline structure will not separate. So there will be a monoventricle, fused basal ganglion, all these problems. So pituitary is also midline, so it will also be affected. That's why there will be a diabetes insipidus. So lysencephaly is basically the failure of the migration, like it's a migration failure. So the problem really, the neurons fail to migrate to cortex. And why brain becomes smooth in lysencephaly, smooth brain. Okay, listen, just remember, lysencephaly, smooth brain. So why the brain becomes smooth? Because no migration, no cortical layering, no gyri, no sulci. And the clinical effects will be like the seizure, dysphagia, microcephaly, facial anomalies. These all will be the problem. No neural folds or sulci, gyri, etc. So the concept here is that there will be let's see basically. So failure of the neural crest cell migration, smooth brain surface that lacks the sulci and gyri, associated with the microcephaly, facial anomalies, hydrocephalies, ventriculomegaly. So just remember these terms, all right. Occulta, only the bone defect, meningocele, meninges will also be herniated, myelomeningocele, both nerves and meninges will be herniated, myeloschisis, there will be exposed cord. Okay, the neural tissue will be exposed. Anencephaly means there will be no brain. Holoprosencephaly, no division of the midline because of the sonic Hedgehog. All right, just remember this. Now let's move to the here I would like to add one more thing regarding the high yield things. So remember the genes, remember the neural tube forms in which week? The 4th week. Okay, Remember, if there is cleft lip, cleft palate malformation, there the problem is the malformation. So cleft palate is problem because it's abnormal formation, malformation, okay, which is the intrinsic developmental defect. Sonic Hedgehog genes knocks out which organs can be defective. You can say neural tube will be defective. Neural crest cell derivatives, you can say the Schwann cell, melanocyte derivative. I already discussed this, okay. Neuroblastoma, neural crest cell, pheochromocytoma, neural crest cell, schwannoma, neural crest cell, melanoma, neural crest cells, cleft lip, cleft palate, malformation, failure of the fusion. Just remember all these things, okay. Now let's move to the next posterior cranial fossa malformation, KRE1, KRE2, okay. So in the abnormal KRE malformation 1 and 2, the bigger picture is that we have the within the posterior cranial fossa we have the cerebellum, brain stem, which is include the bone, medulla, and we have the fourth ventricle. So if there is any problem here, that will lead to, if there is any tumor, any bleeding, any edema or anything, so that will compress the the ventricular system, the CSF flow. It will compress the CSF flow, that lead to the CSF obstruction. So in KRE malformation, a KRE1, so there will be a problem within the cerebellar tonsils. How? Let's discuss it. Ectopia of the cerebellar tonsils inferior to the foramen magnum, the structure number 1, okay. So yeah, so if there is tonsillar herniation through the foramen magnum, it will usually be asymptomatic in childhood. It will manifest in adulthood with the headaches, cerebellar symptoms associated with the spinal cavitations, syringomyelia. So cerebellum is important for balance, for walking. So if there is any problem in this area, that may lead to cerebellar symptoms, and it will associate with the so basically syringomyelia is the cavitation of the spinal cord, and in KRE malformation, the basic problem is that there will be a mild displacement. Usually it's compensated in childhood, so the symptoms usually appear in adulthood, and the clinical finding like the headaches, the ataxia, which is a cerebellar symptom. So syringomyelia, it's which is the cavitation within the spinal cord, and just remember these two lines, that in this KRE1, one structure herniates, which is the cerebellar tonsils, okay, and it occurs in adult and associated with the syringomyelia. But in KRE2 there are two structure herniates. So these two structures are and that's why it's more severe problem. So this include the cerebellar tonsils plus the medulla. So basically in KRE2, herniation of the cerebellum, vermis or tonsils, and medulla. So basically two structures through the foramen magnum. Non-communicating hydrocephalus, more severe than KRE1, usually presents early in life with dysphagia, stridor, apnea, limb weakness. So if you look at this medulla oblongata, we have the glossopharyngeal nerve here, vagus nerve here, responsible for swallowing reflex, responsible for cough reflex, vagus nerve especially. You also the stridor there. So basically and then the different pathways coming down. So all these structures, if you herniate medulla, you are causing these problems, and it's associated with the myelomeningocele, in which the meninges plus the neural tissue herniate, usually in the lumbosacral area. So these were about this KRE1 and KRE2, and just remember that it's severe. The KRE2 is more severe because two structure hernia is there, and when you block the CSF flow through the herniation, then it is non-communicating hydrocephalus. Okay, one is communicating hydrocephalus in which there is no obstruction to the flow. It's not related there. I'm just telling you the type. In communicating hydrocephalus, the problem will be relating to the absorption, okay, of the CSF. that will not reabsorb properly. So the key association we already discussed, myelomeningocele with the carry 2, and in carry 2 the brainstem involvement, it is severe. It occurs in babies because the symptom will appear early. It's severe, and there will be hydrocephalus. Then we have the Dundee-Walker malformation. The problem is that the cerebellar vermis is absent. There will be agenesis of the cerebellar vermis. What happens that the fourth ventricle enlarged, okay, and it becomes a cyst-like structure. Posterior fossa enlarged. It will be like a cystic appearance. So the CSF flow is disrupted. Again, there will be a non-communicating hydrocephalus, and the association is basically with the spina bifida occulta. Now, agenesis of cerebellar vermis, cystic enlargement, fourth ventricle, arrow in B. If you look at this whole posterior fossa is filled with the cyst, and that's filling the enlarged fossa associated with the non-communicating hydrocephalus spina bifida occulta. If you anything that is within the posterior fossa, any mass volume, it's compressing the CSF flow, it's causing the hydrocephalus, which is non-communicating, being the obstructive type. And there will also be agenesis of the foramen lusca and medullae. You know, the fourth, from the fourth ventricle, the CSF passes into the subarachnoid space to the lusca and medullae. Yeah, so then the syringomyelia or the syrinx, it's the cystic cavity within the central canal of the spinal cord, and you can see here these are the cystic cavities. Okay, this is the spinal cord, and you can see this cyst within the spinal cord. So this cyst will compress this anterior commissure. The fibers is crossing in the anterior wide commissure spinothalamic tract basically. So the spinothalamic, from the spine moving to the thalamus, are typically damaged first, results in the cap-like bilateral symmetrical loss of pain temperature sensation in the upper extremity. Fine touch sensation is preserved. Now, as we know that proprioception, vibration, fine touch is to the dorsal column, medial lemniscus system, and here the pain temperature sensation is usually coming like in this pathway. Okay, the pain sensation on the, let's say it's the right side. So the right side pain sensation, it will come here, and then 2 level above it will decussate. So if let's say it's the T10 level, so from the T10 level the pain and the temperature sensation is coming here. It is going at the enter into the T10 level. Then at the level of T10 it will decussate. So 1 to 2 level, T8 or T9, it will decussate above. So that's how the temperature sensation will be, the pain and temperature sensation will be affected in this syringomyelia. And there will be a bilateral, because it's central. So decussation from here, decussation from here, both will be affected. So the cap-like involvement of the, this is the cap-like involvement in the upper limb, the loss of pain and temperature sensation. So associatively carry 1 for malformation. In carry 1 what will happen, you remember that there is one structure herniate, only the cerebellar tonsils, and in carry 2 both the tonsil and medulla will herniate. So it's associated with the cerebellar tonsil only, the carry 1. If you look at this associated with carry 1, low lying cerebellar tonsils in here, you can see here the cerebellar tonsil herniate through the foramen magnum. Alright, and so also scoliosis and other congenital malformation. Acquired causes include trauma, tumor. Most common location is cervical, is more than thoracic, thoracic is more than lumbar, and then so most common is cervical, and it's coming like downward direction. Syrinx. Syrinx is syringe, it's tube. So just remember it's a cystic problem in spinal cord. Now let's move to the tongue development, and it's important because the sensory supply, the motor supply, and everything regarding the tongue is important. If you look at this tongue, the anterior 2/3 of the tongue is supplied by what? You must remember this as just like in your long-term memory. So anterior 2/3 is supplied by the what? Yeah, anterior 2/3 of the tongue is supplied by cranial nerve 7. The spatial sensation by the chorda tendina of the facial nerve, while the general sensation is by the what? V3. Okay, V3 mean the V3 is basically, no, not V3, it's the glossopharyngeal nerve. So anterior 2/3 of the tongue is supplied by facial nerve, special sensation chorda tympani, facial nerve, general sensation glossopharyngeal nerve, posterior 1/3 both general and sensory is carried by vagus nerve. No, glossopharyngeal nerve. All right. So let's read this and let's correct. First pharyngeal arch forms anterior 2/3 of the tongue, sensation via the cranial nerve 3, which is the mandibular region of trigeminal nerve, taste via the cranial nerve 7. Okay, I am wrong here. So taste special chorda tympani, cranial nerve 7. Yes, so I was wrong here. Anterior 2/3 and posterior 1/3. If you look at this diagram, anterior 2/3, the sensory sensation, that the taste sensation which comes into the sensory. So the taste sensation by chorda tympani, it's a special sensation, while the general sensation is by the mandibular division of trigeminal nerve. Posterior to 1/3, both general and sensory sensation is carried by the glossopharyngeal nerve, and the root of the tongue is, the sensation is carried by the vagus nerve. Okay, so this area and this area is, remember, the tongue supply. Now the third and fourth pharyngeal arches form posterior 1/3 of the tongue, sensation and taste mainly via the cranial nerve 9, extreme posterior 1/3 posterior via the cranial nerve 10. Motor innervation is via the cranial nerve 12 to the hypoglossus. So just remember this line. All the intrinsic muscle of the tongue is supplied by the hypoglossal nerve except palatoglossus. Palatoglossus, palate is up, tongue is down. So palatoglossus, vagus nerve. All the other 12 hypoglossal. Now here they write some things like retract and depress. Hypoglossus, retract it and depress it. Genioglossus protrudes the tongue. Styloglossus, draw the sides of the tongue upward to create a tuft for swallowing. And motor innervation is via the cranial nerve 10 to palatoglossus, elevate posterior tongue during swallowing. So this was about the movement of the tongue, and let's move to the, here you can see the taste via the cranial nerve 7, okay, which is the chorda tympani, and posterior 1/3 is by the 9 glossopharyngeal, and the root by the vagus. Pain anterior 2/3 by mandibular region of trigeminal nerve, and pain from the posterior 1/3 by the glossopharyngeal nerve. Pain root of the tongue by vagus nerve. Motor by hypoglossal nerve, okay, and palatoglossus muscle is supplied by the vagus nerve. All right, so this was about the embryology of the CNS. Now we will be moving towards the anatomy and pathophysiology.